workshop. I think we've concluded our program with all of our assigned agendas, and hope you're well, sir. So we've done a total of 24 cases, 4 cases per candidate. I think you've all been supervised by a different consultant in each procedure. Just to give you an overview of today's cases, again, every day you come into the workshop and you're going to notice that it's going to be a surprise every time you go in. I don't think we managed to transmit that case, but you'll be able to review it on the video. You saw a case of gastric outlet obstruction. You can see it when you check the video out. And a very brave attempt was made to try to go through that narrowing. The scope was changed, but it was on the discretion of the consultant that maybe we should just do this case for another day. And but it is something that we can commonly encounter, and maybe every 5th or every 10th case you would see a duodenal narrowing. So your approach to that case should be very meticulous, and I hope you get to review the video once you get a chance. You saw a type 2 injury and how it was cleanly, nicely, and efficiently managed. There was no panic, there was no exhaustion, and it just goes to show endoscopy can also be very therapeutic in these perforations, and you don't necessarily have to rely on other teams where you can manage it endoscopically quite well. You saw a case of a stricture where the cannulation was difficult because the wire wouldn't be able to cross it. A nice case of stone extraction, always very satisfying to look at those. A broken stent, another case that you probably did not get to see through and through, but you saw the SPY, you saw an EHL attempt, you saw, and you can go see how that fragmented stent was removed piece by piece. There was a case of, the last case that we saw, a nice demonstration of pre-cut, how you go carefully layer by layer until you can identify the biliary opening. All of these cases, you would think they're quite rare because you don't encounter them as a trainee, but you can see that in a routine list, they will come, and you will have to find a way to manage them. And it's good that you're a part of this course, and I hope you found it to be productive. Please do give me your trainer feedback forms and give me your course feedback, and I'll collect them myself. And any word from the faculty? Any comments about the cases? वो बस आए 2 मिनट में Sir, we can
Thank you very much, Noel, for organizing such a fantastic course. I think we are very fortunate to have Professor Saeed Qureshi with us. He was the one who actually started the course here. Myself, Saeed Qureshi Saab, and Saad Niaz, we started this course in 2010. And I'm glad he still takes his interest in it and is particularly, attends at least the award distribution ceremony. I've always enjoyed coming here on these courses, and every time I'll go back more enlightened. There's more to learn. There's so much to learn from my colleagues, from you people. So it's always very rewarding, and I think we should keep it going. Our main aim now is to empower our local faculty as well, so that tomorrow they can take the baton and continue this, because it's not just personalities, it's the institution that we should build. And we are very fortunate to have a world-class institution. We can be proud to have something like this. You can compare it to any good endoscopy department or unit in the world, not just Pakistan. I'm talking about world. And I think this is something which we need to be number one, proud of, and also try our best to maintain the standards. So well done to the organizing committee, and I hope you all had a very enjoyable time here. Forget about the success or failure of your cannulation. The main thing is enjoy the course.
We just wanted to show a brief video of disinfection of the scopes in our unit. It's an educational video. You can take it from us as well. It's just a bit of an overview on high-level disinfection process. Thank you. My name is Dr. Novel Zakaria. We are at the disinfection unit at the Sindh Institute of Advanced Endoscopy and Gastroenterology.
अस्सलाम वालेकुम, मेरा नाम फरहान अहमद है, मैं यहाँ पर disinfection in charge हूँ।
Step 1. Pre-clean the scope. The procedural room is where the reprocessing starts. It is essential to begin pre-cleaning as soon as the patient's insertion tube is removed, since this helps to stop any biofilm from forming. If the leftover dirt isn't cleared right away, it may dry up and remain contaminated. Wipe the insertion tube, flush water and air through the channels, and soak in detergent solution to prepare for cleaning. Test. This is the second step of reprocessing. You can find any damage to the scope's internal channels and external surface by performing a leak test. If the leak test isn't done and there is internal damage in the scope, this might result in insufficient disinfection and more endoscope damage. Leak testing must be done immediately following pre-cleaned scopes. The third step is manually brushing and flushing. Cleaning the scope manually is an essential part of the disinfection process. The scope needs to be fully submerged in the detergent for this stage to be completed. Now is the time to place the previously separated parts into the container so they may be cleaned. When sanitizing the scope, use a lint-free cloth or soft brush to clean the exterior. Because residual materials can lessen the efficiency of sterilizing procedure, make sure to brush and flush any residue that might be remaining in the channels and ports. Allow the scope and its parts to soak in the detergent for the duration suggested by the manufacturer's instructions. The fourth step is disinfection. As directed by the manufacturer, for appropriate sterilization or high-level disinfection, adhere to the reprocessing instructions. Chemicals and equipment must be examined carefully to apply best disinfection technique. After the scope is submerged in the solution, run the solution through the channels and let it soak for the prescribed amount of time. After soaking, use forced air to get rid of any remaining disinfectant. Transfer the scope and components into the container of clean water and then remove the scope and place on a sterile towel. Dry with a lint-free cloth. Flush with alcohol. In order to stop any bacterial growth, flushing the scope with alcohol encourages drying of the channels. Utilizing the suction apparatus, aspirate through the channels with 70% ethanol. Next, utilize compressed forced air to eliminate any leftover alcohol. Lastly, clean the scope's exterior with a lint-free alcohol-soaked cloth before using a cotton swab to dry the port. This is the last but essential step for reprocessing. When storing your scope, hang it uncoiled and in a vertical position. This facilitates drying and prevents recontamination. Make sure there is enough space between the devices to avoid damage by contact. For quality assurance purposes, it is recommended to maintain a thorough documentation of the entire process. Having the record can be very helpful in certain circumstances, whether it be due to proper disinfection or recall. Thank you.
charts where we just present quickly because the infection disinfection we're just sharing our project that we started. Asman will take 5 minutes.
Assalamu alaikum, I'm Dr. Asma Yasin. I'm GI Research Fellow at SIAC. And so we have ongoing 5 trials, but related to infection are 3. So this one is the major one, and it is the title is the biliary fluid microbial spectrum with antibiotic resistance and safe reuse of disinfected accessories for sustainable green endoscopy. So the objectives are very clear in the title. Let's just go one by one. So reuse of the disinfected accessories can contribute to environmentally sustainable green endoscopy practices. So we are hearing a lot about the green endoscopy, and we all are aware about its effects. And if we talk about the Pakistan centers and most of the world centers towards our part of the world, they are reusing the accessories. So we want to see this thing also. Plus reuse of the disinfected accessories and risk of infection. Is it a myth or reality? It has never been studied as a trial. So this study is a pragmatic trial, and we are going to study it in a very controlled environment, ensuring the safety of the patient as well. Development of antibiogram based on the biliary fluid culture results. In Pakistan, there is no proper or approved antibiogram. Only 2 centers I know that they have biogram, but it's not specifically for the hepatobiliary system. They have never studied it, and it's just based on the blood cultures. So post ERCP cholangitis rate, duodenoscope and accessories disinfection efficacy by doing the cultures. So this is just the methodology. I'll just go by it very quickly. After IRB approval and screening the patients for ERCP, we have included those patients who don't have any history of ERCP, and they are naive cases. They have no history of prior use of antibiotics for at least 4 to 6 weeks, and they have underlying whatever the pathology is. They might have cholangitis, they might not have cholangitis. They will be recruited in our study, and pre-study we have sent cultures of all 190 duodenoscopes, make sure that they are already culture negative, then we use it for the study purpose. So when we do ERCP, just after the biliary cannulation, before getting the cholangiograms, means before injecting the contrast, we will get biliary fluid for cultures, and 10 ml each in aerobic and anaerobic bottles. Then we will send them for culture. After ERCP, we will disinfect as per the protocol, as per the usual protocol of our institute, I will say, duodenoscope and the used accessories. After disinfection, after proper drying and all, we will send the cultures of those duodenoscope and accessories also separately. And after chasing, we will see, one thing I missed, that blood cultures are also sent before the procedure of patient. So after sending the cultures, we will follow our patient for 30 days. On day 1, day 7, day 14, and day 30, they will be called. It's just like teleclinic, and we follow the patients for cholangitis. If any of our patient develop cholangitis signs, we will call them back. We will get all the cultures repeat, and we'll see whether the infection that our patient has got, it was in vivo or in vitro, it's matching with our cultures or not. In this way, we will fulfill our objectives that I just explained. So any questions or any critique that can improve this, or we can do anything else? Just fly.
There was a question for why we are doing effective blood culture in patients who are asymptomatic, because we want to rule out any asymptomatic bacteremia.
I think this is a really good project because it's going to address number of questions.
Yes, sir.
And hopefully facilitate you and the institution in achieving the objective of, not only providing the evidence for sustainable green endoscopy in the resource constrained setting, but will also help patient care across many parts of the world where patients are not able to achieve objectives. I think my only suggestion to you would be, it's a really good project, and there are a number of things or messages that you can send across. So potentially start off with a really broad objective, and but then you want to basically maybe divide them into
Yes, sir.
subsections, because you can
Yes.
easily achieve posters in many conferences and then come up with a a paper, maybe looking at the two broad themes here. One is obviously your spectrum of the biliary fluid microorganism in this era of antibiotic resistance, and the other is where you sending a message across about how potentially useful reuse of XSCs can be in the green endoscopy. So well done, and good luck.
Thank you, sir. So our next project is, thank you. So, yes, so these were the last guidelines that were published for the duodenoscopes disinfection. That's why we have used it. So next project are related to antibiotics use. Dr. Mustafa yesterday mentioned about the use of antibiotics in ERCP. So yes, what he was mentioning that in Pakistan and towards our center, towards our part of the world, we give antibiotics to almost each and every patient of ERCP, irrespective the system was drained completely or patient was in cholangitis or not. So in cholangitis, no doubt we give antibiotics, but not in cholangitis, still we are giving antibiotics. So the basic purpose of this trial, this is a randomized control trial, to compare the surgical site infection rates. That is, for us, it was clean surgery, that is ERCP. Post ERCP cholangitis rate between the single dose versus extended dose. Oh, sorry. ERCP and PEG, sorry. I was sticking. So it's again the same purpose, that we are going to see post ERCP cholangitis rates between the two groups, that is single dose and extended dose of antibiotics. Extended dose means the one we usually give, that is for usually 5 to 7 days. So we have kept 5 days after ERCP. So I just mentioned that it's a randomized control trial. Inclusion will be the patients who have no history of recent antibiotics use. Okay. And anything else you want to know? Again, it's the same, that we will be following our patients for 30 days. We'll call them back if any signs of infection, and we'll see which group has more infection and which group has not. So, inshallah. The results will be disseminated so that we all can be benefited.
This is interesting because many years ago in Cairo, I met Peter Cotton in one of the meetings, and I asked Peter Cotton that, we use antibiotics, and I'm not sure. He said, do you have the evidence? I said, no. I said, all I know is that, it was different when I was in UK, and when I came to Pakistan, we started encountering more infection. He says, show the evidence and do it. So it took us a long time, but the idea is that in Pakistan, what's happening is that we are giving antibiotics by and large post-procedure for 5 days or 7 days, both for PEG and for ERCP. So we are actually looking at these two arms where we are giving antibiotics and not giving antibiotics, and see whether it's actually any different in Pakistan in our population or not. So this is just trying to get evidence for what we are doing, which I think probably in most cases is not necessary.
We are doing this. It's for all.
This is for all comers, right?
For all.
Because we give antibiotics to all comers. We don't give even peri procedure. Okay, so peri procedure is something that most people in the world are doing or recommending. And the kind of patients we are having, I think that would be probably the next step. If this doesn't show any difference, then we'll probably do it. But I'm pretty sure.
Straightforward in ERCP as well. So we don't do peri procedure, like malignant biliary tract pancreatic cancer. We don't do it.
Peri procedure.
We only use it. It's a different population,
Different settings and everything. So let's say if I was to talk about India or this part of this region.
This region.
Everybody.
Yeah,
Not in America. Or
we only use
I don't know, what is the practice in UK?
No, we don't give antibiotics.
At all?
So we give it for cholangioscopy and PSC.
Yeah, BSc cholangioscopy, that's it.
And immunosuppressed, like cancer.
Yeah,
Organ transplant?
So
Thank you.
बैकग्राउंड चेंज कर दो ये तो कागज जो तुम लोग हर जगह फेंक देते हो इसको दे दो